Hi, everyone. Good morning or good afternoon, depending on where you're joining from. I am Mary Kashak with the Long-Term Quality Alliance, and I'm thrilled today to have this webinar to discuss the launch and release of our latest report with our partners at ATI Advisory, focused on the non-medical benefits within Medicare Advantage. Our webinar today and our report that will be posted later this afternoon is a deep dive on in-home caregiver and social supports within the Medicare Advantage supplemental benefits. A few housekeeping items before we get started on the next slide. I guess first I'll go through the agenda. We're going to have opening remarks from our funders and the supporters of this work at the SCAN Foundation, a brief presentation from our from ATI and LTQA on our findings, and then a panel discussion with 2 Medicare Advantage plans, followed by some questions and answers and an opportunity to engage with you all who are participating today. And now I'll move on to the housekeeping items before we jump into the meat of the discussion. You should see the chat box and a Q&A box at the bottom of your Zoom platform. So please feel free into the chat, enter any comments, any resources you want to share, any insights or aha moments that pop up during the webinar today. And then please use the Q&A function to ask any questions. We will go through those questions in the Q&A box at the end of our panel discussion. We'll save some time at the end and run through those questions in the Q&A box. But for now, let's practice using that chat box. We would love to know who has joined us for today's webinar. So if you could go into the chat and just let us know your name, your organization, and where you're located. I know that we had a lot of different stakeholders who were registered for today's webinar, and it's always nice to know who else is participating. So I'll give it a moment for folks to go ahead and enter in your name, your organization, and where you are located, because we would love to hear from you. And while people are doing that, I will introduce our speakers. So we have Narda Apache who is Vice President of Policy at the SCAN Foundation. Narda is an experienced health and aging policy professional with deep expertise in policies and programs that support older adults, including Medicare, Medicaid integrated programs, and long-term services and supports. Prior to joining the foundation, she served as the Medicare and Medicaid Policy Director for the United States Senate Aging Committee under the leadership of Chairman Bob Casey of Pennsylvania. Prior to the Senate, Narda spent around 15 years in the private sector, primarily in Medicare and Medicaid policy consulting. Next, we'll have Christina Wu, who is the Vice President of Policy and Research at the Long-Term Quality Alliance, a 501c3 membership organization aimed at improving outcomes and quality of life for people who need LTSS and their families. Christina leads our research and policy agenda to advance person and family-centered integrated long-term services and supports through research, education, and advocacy. Prior to joining us at LTQA, Christina spent multiple years in research, government, and healthcare consulting in the Medicaid and LTSS space for clients including the Center for Medicare and Medicaid Innovation, the Department of Housing and Urban Development, and several state Medicaid agencies. And last but certainly not least of our presenters today, we have Bill Winfrey, who is a director at ATI Advisory, our partners in all of this in this great project. ATI is an advisory, research and advisory firm focused on transforming healthcare to reduce cost and complexity for everyone, especially individuals with high needs. Prior to joining ATI, he spent 7 years in federal service, most of that time at the Center for Medicare and Medicaid Innovation, CMMI, the testing grounds of new ideas within the Medicare and Medicaid programs. At CMMI, he was specifically focused on health equity and social determinants of health and the links between healthcare and social service sectors. So with that, I am going to go ahead and turn it over to Narda to kick things off.
Thank you so much, Mary, and good morning or good afternoon, again, based on where you are. On behalf of the SCAN Foundation, I am so pleased to introduce this session, which draws on several years of work around non-medical supplemental benefits and Medicare Advantage. And also just really want to appreciate and organizations represented here, and I'm very excited to see that as well. For those of you who are not familiar with the SCAN Foundation, we are an independent public charity devoted to transforming care for older adults that preserve, in a way that preserves dignity and independence. My name is Narada Apache. I'm the Vice President of Policy and have been with the foundation now for about 6 months. And as Mary mentioned, most recently had been serving on the Senate Special Committee on Aging, where a lot of the issues that we're going to be talking about today were just incredibly prevalent. We heard all the time about, older adults who weren't able to afford, their long-term services and supports, weren't able to get, relief or support for their caregivers, but weren't at a stage where they were spending down to Medicaid or didn't want to spend down to Medicaid to be able to access some of those broader benefits. With the passage of the Chronic Care Act in 2018, the creation of special supplemental benefits for the chronically ill, or SSBCI, as they have been known now to all of us here, as well as additional guidance from CMS, which expanded the definition of primarily health-related as it relates to supplemental benefits. The Medicare Advantage program now has the opportunity to provide some of those non-medical supports to individuals eligible for those supplemental benefits. And specifically here, we're really focused on in-home services and supports, caregiver supports, and other social needs benefits. I just really want to thank ATI and LTQA for their leadership in terms of the analysis done on these benefits and generating that public awareness and awareness among policymakers, as well as the health plan community and others that are actually offering these benefits. I think we all appreciate and recognize that supplemental benefits may not be able to be the sort of panacea in terms of solving the long-term care crisis, but there is a lot to be learned and a lot of evidence that has been generated over the past several years, and ATI and LTQA have really been on the forefront of leading that research. So with that, just again, thank you for your participation today, and I'll turn it over to Christina.
Thanks so much, Narada. So before we go into some of our research findings, I'm going to provide a little bit of background for everyone to level set. So a lot has changed in supplemental benefits. Next slide, please. A lot has changed in supplemental benefits, or benefits that Medicare Advantage plans can offer above and beyond the base Medicare benefits. Prior to 2019, plans were allowed to provide additional benefits through their rebate dollars from Medicare. And these benefits had to be primarily health related, and they had to be offered uniformly to all plan members. These benefits typically took the form of vision, dental, hearing, and over-the-counter benefits. So interestingly, at the same time in 2018, both the Centers for Medicare and Medicaid Services and Congress expanded supplemental benefit authorities. CMS made changes to the definition of what could be included as a primarily health-related benefit. That meant that long-term services and support, LTSS-like benefits could be offered for the first time in Medicare. And they allowed benefits to be offered with more targeting via uniformity flexibility. Congress passed the Chronic Care Act, which created special supplemental benefits for the chronically ill, or SSBCI, which did not have to be primarily health-related. So that included things like food, pest control, non-medical transportation, social needs benefits, which were allowable for the first time to chronically ill enrollees. We've also included on this slide uniformity flexibility and value-based insurance design, or the VBID model, as additional authorities under which plans can offer non-medical supplemental benefits. However, we are studying UF and VBID only to the extent that these authorities are being used to offer non-medical supplemental benefits. So you'll see that reflected throughout the rest of this presentation. Next slide, please. All of these new authorities have been introduced over the last 6 years. So while plans could begin offering expanded primarily health-related benefits in 2019 and SSBCI in 2020, by 2023, nearly 40% of Medicare Advantage plans offer at least one non-medical supplemental benefit. Next slide, please. All of these supplemental benefits are paid for using premium and rebate dollars. So in 2022, the average rebate dollar amount that MA plans received was $164 per member per month. On average, only $36 were being used on all Part A and B supplemental benefits. So that is not just these non-medical supplemental benefits we're talking about, but all supplemental benefits, including dental, vision, and hearing. Next slide. So this next chart gives you a sense of how these dollar amounts stack up to the monthly costs of LTSS. So as you can see, the scope of these benefits in Medicare Advantage are limited, especially compared to the services that are provided to the dually enrolled population as LTSS and home and community-based services, which are significantly more generous in Medicaid than those offered as supplemental benefits. Next slide. While the funding for and scope of these benefits are limited, still, these changes represent an unprecedented opportunity to bring non-medical services to Medicare beneficiaries. So recognizing the magnitude of these changes, ATI and LTQA, with the support from the SCAN Foundation, convened a group of healthcare leaders across various industries to develop what we call the guiding principles for implementation of these benefits. You'll see that the core principle is that these benefits reflect individual needs, and through collaboration, that these benefits are understandable, sustainable, and equitable, and that they evolve with continuous learning and improvement. This group, called the Leadership Circle, and these principles have guided our research on these benefits over the past several years, including our most recent research, which we're delighted to present to you today. Next slide. So today we are pleased to release our new report, which is a deep dive into 3 specific benefits: in-home support services, caregiver supports, and social needs benefits. Our research is informed through over 24 interviews with MA plans, benefit providers, Medicare enrollment navigators, and other stakeholders, and our review of the literature, publicly available data on benefits from CMS, as well as plan documents. So we invite you all to review this report in more detail, which will be available on our website later this afternoon. Next slide. For this report, we did a deep dive into the three benefits that I just highlighted. So IHSS, which are services that provide assistance with activities of daily living and instrumental activities of daily living, ADLs and IADLs. Caregiver supports, which are services aimed at the caregiver member dyad, and social needs benefits, which seeks to increase social connectedness among eligible members. So we selected these 3 benefits for several reasons. Number 1, these benefits are typically human delivered and aim to address needs that are best addressed by human-centered connection and support. Number 2, the benefits have a fairly broad definitions that are not always clear to the general public what they entail. Number 3, these benefits resemble Medicaid LTSS and potentially address a gap in these types of services for low-income individuals that are not yet eligible for Medicaid or LTSS. And for number 4, the number of plans offering these benefits continues to grow each year, despite the challenges in offering these benefits compared to more straightforward benefits like meals, for example. So for these benefits, we sought to understand the design and generosity of each benefit offering, the rationale for plans to offer these 3 benefits, and the impact of these benefits on beneficiaries to the extent that we were able. So without further ado, I'll turn it over to Bill Winfrey to share some key highlights from our research.
Thanks, Christina. So Christina has laid the foundation for us, and I'll dig further into what we found with our report. We'll hit the highlights today, knowing that we want to focus on hearing from the expert panelists, and that we also want you to dive into the report. And these first few slides I'll go through relatively quickly, but we'll share afterwards so you can dig in. Next slide, please. So as part of this work, we track the number of plans offering at least one non-medical benefit through any available authority. We continue to see growth. Since 2020, across all new non-medical benefits, there's been a 203% growth. And as Christina mentioned earlier, 40% of MA plans are offering one of these benefits, as opposed to the 17% that offered them in 2020. The link at the bottom right of this slide takes you to a separate resource with comprehensive data on these benefits. Next slide, please. When we narrow in on these three particular benefits, we see even greater growth than the 203%. So not cited on this slide, but over 1,600 MA plans, 28% of all plans offer at least one of these three benefits. Nearly 1 in 4 plans are offering IHSS, and 1 in 10 are offering caregiver supports. Next slide. And we see ongoing geographic growth in the benefits. These maps display counties with at least one plan offering one of these benefits, with 2020 on top and 2023 on the bottom. In addition to the growth, there's expansion within these counties. So for counties that are in the darker red, those represent counties with at least one plan offering these benefits. IHSS is now offered in an average of 10 plans per county, up from roughly 3 per county in 2020. Next slide. In addition to the growth, we don't expect these benefits to go away. Some of the key data points that we see indicating a need for these benefits are listed here. ADL needs, caregiver supports, and social isolation. And it's worth noting, COVID hit at just the time that plans were first offering these benefits, certainly exacerbating issues related to social isolation and loneliness, but also likely impeding the ability for individuals to get services in person for these needs. And one of the recurring themes across these benefits is the in-person delivery of the benefit. Plans and providers are likely still adjusting to this new reality. Next slide, please. So on this slide, this is a display of experimentation in benefit structure and generosity. What is shown here is the annual hourly limits for IHSS and plans. In general, it seems like plans are moving away from small restrictive hours on IHSS, which you can see in the red slice of the pie. The story is mixed though, because if you track the pink slice, it increases in 2021 and then decreases in 2022. Now this could be the same plans offering 60 or more hours because the total number of plans is increasing. But it's clear that plans are continuing to try to hone in on that right blend of hours to meet member needs, but also limit their costs, among other considerations. And it's worth noting, as Christina noted, that while more generous is generally good for members, we're still talking about 24 or 60 hours available per year. So it's important to keep in perspective the scope of these benefits. Next slide, please. So here we move to more concrete examples of plan experimentation. We pulled specific descriptions of these benefits from evidence of coverage files that we found to exhibit what we're talking about. So starting from the left, with Scan Affirm, they're targeting here, using IHSS explicitly for post-hospitalization. It notes that a member must request services within 7 days of discharge. For Ascension, they're showing flexibility at play. They're using helper bees, an aggregator of providers across benefits, and making IHSS, caregiver supports, and a range of other benefits available to their members. Humana on the right has a flexible SSBCI benefit where members can receive caregiver supports or IHSS, among other things, and members engage with a care manager who coordinates and authorizes services, as well as assisting members to identify service providers and connect with a range of available resources. And finally, Cigna is an example of wide-ranging supports, including care coordination, coaching, and stress management targeted at caregivers, and explicitly mentioning both members and non-member caregivers as recipients of the services. We'll also hear about the innovative benefit offerings from Molina and Blue Cross Blue Shield of Kansas during today's panel's discussion. Next slide, please. So to summarize some of the trends we saw in benefit design across these benefits, 3 things stood out. The first is human delivery. We saw plans actively engaging or using providers to engage in the delivery of these benefits, serving as care coordinators of sorts to help customize the benefits to an individual's need. This aligns with our core guiding principle for this work of ensuring that these benefits reflect individual needs. We saw targeting. Plans are developing creative solutions to target, whether it's IHSS as a post-hospitalization benefit or caregiver supports offered directly to non-member caregivers. This also reflects targeting that occurs across the different authorities available to offer these benefits, SSBCI and VBID in particular. And finally, we saw flexibility. One of the themes across these benefits is the flexible use of them. Because of overlapping services between these benefits, plans can in some cases use these benefits interchangeably and leverage that to target or structure a benefit differently, depending on their particular need. For example, targeting a certain slice of membership or appealing to caregivers rather than members. And in some instances, the exact same service could be filed across all three benefit categories. Next slide, please. So to summarize, members have clear needs in the areas that these benefits are intended to address, and plans perceive these benefits to be responsive to those needs. The benefits are often offered as part of a package that members can use to address their individualized needs and can adapt the services to changing needs over the course of a year. Beyond meeting needs, plans see these benefits impacting member satisfaction and retention. And then to preview the next slide, there are actions that can be taken to support more Medicare beneficiaries in having access to benefits that can meaningfully meet their needs and are delivered in alignment with the guiding principles. Next slide, please. I'll go relatively quickly through these, but please see our report for more expansive explanations of each of these actions. Plans can tackle a few things in offering these benefits. They can improve the targeting of IHSS to make optimal use of limited hours. They can standardize identification of caregivers to improve their ability to reach them. And they can improve data collection and publication of findings on these benefits. CMS can also help by similarly improving data collection on these benefits, by clarifying benefit definitions where there is confusion, and then also clarifying the confusion that we heard from plans around their ability to offer caregiver supports directly to non-member caregivers. And lastly, CMS plans and enrollment advisors, brokers and SHIPs in particular, can work together to get direct feedback from beneficiaries on the benefits and improve the education that is made available to them. And with that, I'll hand it back to Christina to transition us into our panel discussion.
Thanks, Bill. So we are so thrilled today to be joined by representatives from 2 Medicare Advantage health plans who are innovating in this space and can add a little bit more color to some of those findings that Bill just discussed. So first, Janice Gilmer Gentry is the manager of CMS programs at Blue Cross and Blue Shield of Kansas, BCBS-KS, where she has worked for more than 24 years. In her current role, she led the development of several products to include health, dental, and other ancillary products in the individual, under and over 65, group, and Medicare business. And David Rule is the Associate Vice President of Medicare Analytics and Product at Molina Healthcare. David has spent his career working on public problems, focused on developing tools that improve decision-making and applying a model-driven approach towards tackling public health and infrastructure issues. A lifelong caregiver, he is particularly interested in solving the problems encountered by dually eligible individuals. So thank you so much, Janice and David, for joining us today. During this panel, we'll dive into the scope and breadth of the benefits that their plans offer, how plans are strategically reaching members with these benefits, and why plans choose to offer these 3 specific benefits. And throughout our research, we identified 3 key questions that MA plans consider in deciding to offer and how to design these benefits, which will guide the structure of our panel discussion today. So those 3 questions are: first, what do our members need? Second, what can we do to help meet those needs? And third, how can we best deliver those services? So we can kick off the panel here with an introductory question. So I'm going to pose this to Janice first. Can you please describe at a high level which of these 3 benefits you offer and how they fit into your plan's broader strategy for supplemental benefits and your broader suite of offerings?
Sure. Thanks for having me today. Blue Cross and Blue Shield of Kansas, we're currently offering what we're calling the Healthy Aging Support, also known as Caregiver Support. And this benefit provides members as well as their families with a unique opportunity to kind of individualize their needs at every stage in their life, to include connecting the members with providers, local community resources, in addition to support for their caregivers. During this program, if members choose to sign up, their caregivers as well as the members are assigned what we call a care guide, which is a licensed social worker. Members engage with that social worker throughout their journey. They engage however they feel comfortable with. That can be via a phone call, a video call, text, or an email. Some of the services that the care guides assist the members with are some post-discharge assessment, which includes, how they're feeling. Do they understand their discharge instructions, as well as do you understand your medication requirements, or, when to take what type medication. And luckily also, I will add that how have you talked with your provider, your PCP, to kind of understand how those medications might interact with each other. They also do a virtual fall risk assessment by just kind of on a video calls, they can assess, have members kind of walk through their homes to just kind of do that virtual risk assessment. Also reminding the members about any appointments that they might have, coordinate any type of services like, return, follow-up visits, things like that. Medication reminders. Are you talking with your families? Do they understand, what your needs are, what your concerns are, as well as communicating with those family members that they might identify. Do you understand those post-discharge instructions as well as connecting members with some virtual social programs to help reduce some of those social isolation issues, things like virtual bingo, virtual concerts, and then lastly, connecting them with any type of senior center resources that they might have in the community.
Thanks, Janice. That's all really interesting, and looking forward to continuing to dive into more of that throughout this discussion. And just want to welcome the audience here to enter any questions that you have on what's being discussed in the panel, in the chat, or the Q&A, and we'll get to those questions during the Q&A portion of this event. So then we'll turn over to David. Can you please describe the benefits that you all are offering under these 3 categories of interest?
Yes, and thank you again. So our big offering is IHSS across the portfolio. It's offered as an hours allocation on virtually all of our Medicare Advantage plans, whether it's a DSNP or it's just a traditional MA design. The way that it's structured is a member can utilize those hours for a pretty wide range of support activities. It could be assistance around the house or trips to the grocery store or pharmacy. It could be used for, just general companionship style, things you might want to use your grandchildren to do. It's non-clinical in nature. People have used it as a ride supplement. That's actually been a use case we've seen. And that's kind of the general theme of that benefit. The way that it's delivered is it's enrolled, all members on our plans where it's offered as a benefit have access to it. When a member is going through the onboarding process during their initial enrollment, we discuss the benefit during that process, and then during our welcome call outreach that we do with members, it's discussed there, and the case management team is very aware of, say, the member having access to this benefit, and we try to encourage it and use it as an extra set of resources that we can use to affect, say, outside of our episodic interaction with membership too. In terms of social needs, we offer an allowance for mental health and wellness applications as part of our SSBCI program. We offer other SSBCIs as well, but that's kind of been a fledgling benefit. We haven't necessarily seen the adoption that we have with the other SSBCIs and that, but the design and the intent of that benefit is to center it around kind of like community or just general wellness, virtual engagement, and for members with a qualifying chronic condition. Caregiver support, we're not doing anything as a formal benefit on the Medicare side right now, but what we do is, again, as we are heavily focusing, recognizing that a large portion of our membership is dual eligible and on a DSNP plan. We are generally thinking about the care of the member as having some type of caregiver or some concerned individual in mind. And so we have a lot of playbooking around caregiver support and a team who's kind of geared up to focus on assisting members with a caregiver in mind as well.
Thanks, David. And that was really helpful and sets us up well for the rest of the discussion. So I think the first kind of key question we highlighted was, what do our members need? And we're really interested in learning a little bit more about how you all determined that functional needs, caregiver needs, and social isolation were member needs worth exploring, designing a benefit around. And what sources of information did you look to identify those needs and how to start thinking about how to address them? So first I'll pose that to Janice.
Sure. So we leveraged the social determinants of health information data that we have in our commercial programs. And so what we're seeing in our community, specifically the state of Kansas, I will add that for our Medicare Advantage population, we're not in the entire state. We're limited to 26 of our counties of the 103 that we serve today. So within those 26 communities, we dug into our commercial data for our over 65 population. And what we're seeing as a trend in our state is that where our growth is from a population perspective is definitely in that over 65 market. And so reviewing that data, we determined, there were needs for assistance in navigating the Medicare program, specifically in, some of our food deserts, mental health services, those types of things that's impacting our seniors today. In addition to, I think, as Bill spoke earlier about, our review, when we start looking at this particular caregiver support benefit, it was COVID had just hit, right? And so, just reviewing all the data and all of the concerns with social isolation and the impact that COVID was having on that particular issue, we decided, hey, this is the perfect time to really kind of dive in, review, what some of the partners are out there, what they're doing in this space, and how we can leverage that in our Medicare Advantage program.
Great, thank you for sharing. And David, can you talk about how you, Melina, might approach that similarly or differently?
Yeah, and I think COVID really coincided with kind of, as we were looking at SSBCI as a serious part of our program development, COVID made very clear some of the limitations that we were having around service delivery in our traditional benefit design. And so looking for more kind of broadly applicable benefits that we could provide to a population, especially particularly around things like transportation and loneliness and isolation did become very big considerations in the data set. And honestly, in what we saw in our experience data from just from member feedback, both in the contact center and then in our appeals and grievances data, the availability was becoming a big issue. And we were looking to very actively pivot our program away from being tied to specific, say, service providers, and giving the member back some flexibility and agency in their own lives. And we saw in particular, IHSS is a way of being able to do that. And the SSBCI program is a way of kind of, again, just giving more options and additional resources to members in a time where we knew that their traditional style engagement with a Medicare Advantage plan was going to be significantly lower than it had been, in prior years, in terms of, say, like a human interaction perspective. In terms of how else we got there, we spent a lot of time. We look at a ton of data. I'm an analytics guy. The large portion of my day is spent trying to tie back some type of claim or some type of assertion about what we should be doing with the product back to a number of data sets. And we're very wide ranging how we look at that. We take there's a ton of great public information out there that we use to kind of develop kind of our modeling. That could be census data. There's a lot of experience from groups like this that are very relevant, and we kind of blend what we see there with then our internal experience data, and we are very heavily member engaged as well. We have advisory committees that were kind of telling us this is where they wanted us to see us go, and we put it all together, and it became very clear, I think, where we needed to progress.
Great, thank you. And I think that'll be an interesting theme to kind of highlight throughout, is that there's this emerging need from the data, from the population, and then COVID exacerbates it, but then at the same time makes it more challenging to deliver, since folks don't necessarily want people in their homes. So kind of segueing into the next question around what plans can do to help meet those really salient needs that you've identified. So how did you approach identifying potential solutions that could help to address these member needs? And what factors did you prioritize as you were assessing and selecting solutions and vendors for these specific benefits? So we can start with Janice.
So sure. So kind of leveraging the data that we were able to gather from our commercial market, because what we're seeing is our senior populations that's currently enrolled in our Medicare supplement plans. And like I said, we're new to the Medicare Advantage space. We launched our first plans in 2020. They're similar. Their behavior patterns are similar. And so that's the approach that we took. The needs of our current over 65 population are going to be similar to our Medicare Advantage population. And so with that, we went about, the traditional thing of sending out RFPs, what does your solution offer? And then how, are we limited to, members only? Can we offer these benefits to caregivers? And do the caregivers have to be members? So all of those various different questions we kind of included in our decisions. Another thing that really aided in that decision was, as with COVID and everything was shut down, right? So we're limiting access to folks, particularly in our over 65 population, our most vulnerable population. We wanted to, hey, a virtual offering is pretty cool. We looked at folks that had folks in, they would actually send folks out to visit the members versus virtual. And so just with all of those different pieces and parts, it kind of played a major factor that virtual engagement made an impact on our decision. Also, that what also kind of solidified our decision was the fact that the partner that we selected, they had that clinical component, right? They had the licensed social worker who could, help and kind of navigate the Medicare system, because that's what they're kind of, they're used to doing that today. Also, another key factor in our decision was, looking at other potential partners. That interaction with with our member wasn't consistent. It could be this care, this aid this minute, this month, and then the next month it would be this aid. And so we thought it was very important that our members had a consistent presence, that person that they engaged with was consistent, to kind of help build that trust in that relationship. And so those are just some of the factors that we looked at and when we made our decision to partner with who we partner with. So thanks.
Thanks so much, Janice. And especially at that point around if you're targeting a member that's a caregiver or a caregiver that is not, or a member that is caregiver themselves, or a member's caregiver that's not a member. I think that's a really key question that emerged from our research that was a point of confusion. So really, really helpful to hear that. And for David, could you talk a little bit about how you identified potential solutions, and building off of that, what factors and considerations you examined both in identifying the solutions and designing the specific benefits?
Yeah, I would say first off, just to get it out of the way, the big thing was you need to have enough hours, you need to have a rich enough benefit to make sure that you can sustain engagement, throughout the calendar year with a member, and understanding that not every member is going to use this all the time, so they're going to have a big benefit. You do, like, if you want it to be meaningful, it needs to kind of, especially with kind of as we push into SSBCIs as well, managing, say, some of these social factors, even if they're not necessarily identified as chronic conditions, but kind of in the same way, and understanding that we want to be able to sustain engagement and develop a relationship with a member using these benefits was big. And so we really invested in making sure that we could provide a meaningful amount of time, that if a member is utilizing, it's not something that's going to, come August, they're going to run out of it, and then we have something of a care gulf. We are very protective of how our member who is engaging with our members, and how their data is being represented and used by the potential partners that we kind of went through. There's a lot of startups and people trying to do work in this space, and it's not necessarily we've seen just in the context of this, but just throughout supplemental benefits and Medicare service delivery. There's a lot of health tech and new players in the space, and making sure that they understand kind of how serious the privacy and compliance concerns, and making sure that they're able to that what we're contracting them to do is the sole scope of their interest in the member, and making sure we're aligned in member ownership is a very big thing. And we spoke with a lot of vendors at the top of the funnel before actually choosing our partners, to make sure that where they were going in the trajectory and how they saw their own product development was consistent with how we saw our own. It's the compliance, the ability to share data. Those were really big. Making sure the benefit was rich enough was another big factor. And then making sure that it was actually going to mitigate the needs that our members were seeing, and seeing that COVID year as kind of our base period, that we were kind of evaluating what our next cycle was going to be like. It was very useful because we have seen mitigation in some of those things, and I'm sure we'll get there. But the big thing I wanted to say with that, though, was as we needed to make sure that they were able to do the things that we actually were seeing issues on, right? And so we needed a partner who had enough scale and enough human delivery on tap to be able to meet those types of needs throughout a year too. So scale was a big thing.
Great. Okay, so looking at the time here, we want to move into the Q&A soon. So I want to ask about member awareness. So are members aware of the benefits, and are they making use of them? The question of this webinar is, are these benefits meaningfully meeting members' needs? And would love to hear your perspective on that. We had a follow-up question, I think, which would be good to cover here, about how whether these services are offered proactively or only as requested by the beneficiary or caregiver. So if you kind of speak to that as well. Whoever wants to take this one first. You want to start, Janice?
Sure, I'll go. So caregiver support, it's like, what does that even mean, right? So, I mean, we use this term in the industry, but to the layman's person, it's like, what does that even mean? And so when we onboarded our partner, we went upon a series of communication journeys, right? So we sent out at the very beginning of the year, the benefit year, we sent out, communications to the member, a packet, brochures, and different things like that. And then upon there, we took upon a email journey, a 7-series email journey, just further educating them on what the benefit is, how to enroll, those types of things. And then lastly, we also included them in our onboarding, our new member outreach campaigns. And so we called every new member and just kind of said, hey, we're here for you, understanding that this type of benefit is just only valuable, right, at the time that it's actually needed, right? And so just again, reminding the member, doing some education on what the benefit is, what do you have access to, and just to let them know, hey, we're here for you. And so that's really how we went about educating the member on the benefit, that they had the benefit available. And then I will add, annually, we do that 7-part email series again to just kind of reminding the folks, hey, we're here for you. This is what the benefit is about. No cost to you. And so that we're here.
Great, thank you for sharing that, Janice. And David?
Yeah, our experience is very consistent. The strength of our ability to educate the members and help them see this as a set of capabilities that they have is directly tied to, to how much value they've seen in getting them to meet their needs, right? And that was true internally first. So once we, it's easy to file a benefit, and it's very easy to put something on an MA plan doesn't, you don't need to move a mountain necessarily. But if you really want to actually drive impact to the members, that entire value chain, from writing the benefit, making sure it's integrated into your care documents, making sure that you have the appropriate guardrails and partners with those partners and guardrails with them to do service delivery, was all very much part of, say, our initial implementation and kind of pilot, particularly in IHSS. As we've gone, we've steadily seen that we've seen a consistent uptick in utilization of the benefit month over month. And right, just people utilizing it doesn't necessarily mean it's, is it actually achieving the objective? But what we have seen is people, our members are using this as a benefit to derive real value from, right? They're not using it just necessarily for, we're seeing, right, it's a lot of trips to the pharmacy that they weren't getting otherwise. It's cleaning the house. It's helping people move and transition. It's helped us identify other life events that members are going through that we don't necessarily think about just in terms of medical operation, but are very, very big in terms of, especially for like our consumers with a very limited set of financial resources. It's helped us kind of understand what are the other things we need to manage for, and again, be another kind of source of emerging need data.
Great, thank you both. So what I'm hearing from both of you is that there are ways to design these benefits and really leverage them and plug them into broader care operations to really maximize the meaningfulness and impact on beneficiaries. And that's really exciting and valuable for us to hear. Okay, so wrapping up the panel here, then we'll move to Q&A. We just wanted to give a final question. 1 minute, we're going to ask 1 minute each from each of you. So based on your experiences, what is the greatest opportunity and the greatest challenge to the continued uptake and utilization of these more human-powered benefits to address these functional needs, caregiver needs, and social isolation? So I think we can start with Janet. I think you're on mute.
So sure. The most challenging, I think, is just getting members to understand what the benefit is, right? And then secondly, that they have access to this benefit at no additional cost. And then lastly, just the trust factor. We're an insurance company, we're really not trying to dictate your life, right? We're really here just trying to help you. We really care, right? So that really is just to remove any type of skepticism that they might have in receiving these services from their insurance company. And then I think the most greatest opportunity really is just, getting that data, understanding the data, connecting the members with the local resources that we have available, and then just really to David's point, it's just kind of mining that data once we do collect it and understanding, trying to manage and mitigate risks, at the end of the day for the health plan. So that's our greatest opportunity.
I think, you guys probably remember me going this off of our initial call, but I think that there's I don't think we've seen what the final kind of what the next generation of these benefits is going to look like. Yeah, I think we're in a transition period, and what we see is there's the data sharing is a big thing because most of the relationships that we have for service providing or from our service providers. In a supplemental space, they don't have any of the integration natively, that they do for other components of our plans. So there are things that we specify and we push for, and integrating and being able to use that real time and give the feedback that we get, creating a solid feedback loop, I think is the greatest opportunity, where having integration between what's happening anytime anything happens with a member, getting that back to the plan, since the plan is it's the major point of coordination for services across two program entitlements. Generally, there's our case management staff, outside of just the benefits we've talked about today, does a lot in terms of making sure that there are other community services connected to a member too. Members are used to us as a point of triage, but having that information at our disposal it's a very arduous task right now. There's not a lot of integration or consistency in terms of, say, how these types of entities talk back to a plan or how they need to talk, say, to the regulators too. So I think there's a huge opportunity there as we see technology hitting the platform. If it's hitting it judiciously, then there's everyone's going to benefit, most of which most largely the member. The greatest challenge with any human powered benefit is the fact that you're putting more humans in contact with your members. And, that's something, if there's something that keeps me up at night, it's that. It's like, I after this call, I'm going to go with my father-in-law to a PCP appointment. That's something I take very seriously. And when you're providing any of these things at scale, is the person who's boots on the ground having that interaction with the member, taking that same attitude towards how they do their job. And the other thing we've seen towards COVID has been that this concept of a gig job, or I guess maybe a gigification of a lot of these types of things, where people aren't necessarily providing these as FTEs. They're probably contracted employees in some way. And it's just something to be mindful of, because if you don't have alignment in that perspective with the person who's there, even if they're in a non-clinical capacity, it's tough to get the impact that you can.
Well, thank you both so much. This has been really enlightening and just super helpful to help the audience really understand all the considerations and complexities that go into designing for these needs in your membership. So I know there's tons of questions. We could talk about this forever. We have about 5 minutes. I'm going to turn this difficult job to Mary of figuring out what the best questions to ask here to close us out on.
Yeah, and I guess I'll just say that thank you everyone for putting so many questions and being such engaged participants. We would love to continue this conversation for longer than an hour, but since we only have an hour today, I think we'll go through as many of these as we can, and I'll just note that we will be making the recording, the slides, and our report available to all participants. We'll send that out after the fact. And for the questions that we aren't able to get to, we'll do our best to answer those and build them into an FAQ document that then we will share on the landing page with the other resources for this webinar, because I think we had some really, really great questions that were coming into the chat. So we did have a few that were around specifically the uptake of these benefits. So do you all as MA plans know what the uptake of, how many eligible beneficiaries are in your plan? How many of the eligible beneficiaries are actually accessing the benefit? And then how are you evaluating kind of the overall impact of this benefit over time to determine, tweaks that you might want to make or what you continue offering from year to year? I'll turn it to either one of
take the
you.
question first. So,
Yeah.
So as I stated earlier, we're in like 26 counties. And so our membership is relatively small. We're approximately like 4,000 folks. And so all of our members have access to this benefit. To date, we have about 7% of our members participating in the program. And just kind of talking to our partner, they're used to seeing like roughly 3%. So they're really impressed with the level of participation from our members to date. From an evaluation perspective, I will say that we meet monthly with our partner, and we are walking through the cases that they bring, some of the conversations that they're having with the members. And from there, they're able to connect the members to community resources, other partners that we have embedded in our MA program. And so from a member and evaluation perspective, we send out pulse surveys. We're constantly surveying our members just to kind of gauge their status, if they're satisfied with the program, what other benefits that we might want to include in our offering. And so just for the lightness of I'll turn it over to David.
So two different programs, but for LTSS, we've seen, I think, 12% of the eligible population utilizing it. For SSBCI, I'll have to get the stats, but I think right now SSBCI is probably around 15% or so as well. The average amount of hours, I was trying to pull up and make sense of for whatever the latest is, but I think in terms of, say, engagements that we've seen, I think the average number of engagements for a utilizer over the year is 8 right now, 8 engagements over the course of a year. Again, this is off of the pilot population. In the pilot population, those plans, it's slightly different than how it's been being released into what's 2023 for us. But yeah, we've seen good uptake. We're in the middle right now of, we have an analytics project going on to evaluate kind of across all of kind of our different care metrics, how this population differentiates from the non-utilizing population. So we're actively looking at the results now. We know there's a relationship. We're just trying to quantify how strong it is.
You're on mute.
There we go. Am I muted now? There we go. Thank you both so much. And since we just have about 60 seconds left, I am going to say that, we have so many wonderful questions that come into the chat. So we will be building those into an FAQ, and we'll share those with registrants within the next few weeks. Please check out our existing work in this space. A lot of the questions that came in were around how you as MA plans are choosing your providers and who you partner with on this work. We covered that in great detail in our first practice report that we did as part of this work, really diving into how MA plans are kind of choosing their partners in this work. So we have a lot of data, practice, and policy resources up on our landing page for this project that I encourage everyone to check out. And I just really want to thank David and Janice, both of you, for sharing your experiences and your expertise and being willing to continue engaging with us on this important research and this important topic. Thank you to the SCAN Foundation for your continued support in this work and recognizing the importance of helping Medicare beneficiaries get access to non-medical benefits and the importance of long-term services and supports. And with that, I want to thank all of our participants for being so engaged today. And please keep an eye out for a lot more coming from us in the next few days. So thanks, everyone, and enjoy the rest of your Monday.
Thank you.